Here that this troughing that we've done there's absolutely no hole here at all, and I am convinced that there is no MB2. And I suppose in a way, if you look at this tooth and you've not done the root canal treatment, you might say, well, 90% of teeth have MB2s. And then I'm also going to use an orifice opener here, and this further confirms where the DB canal is. And what we'll notice now is I've got a new GP cone, it's crimped, and now it fits properly to length. And when we take it, so hello, welcome to this week's Friday clinical case. And this is kind of a case which is a follow-on from last week's case, which is essentially looking for that elusive MB2. And I suppose if you didn't look at last week's video, it was a very interesting video. It was where I did a root canal in upper 6 and I found an MB2, and this was a follow-on from a few comments and a few likes from people where they say I upload these videos and I do root canals in upper molars and I never find the MB2. So I wanted to show you two cases. Last week was finding an MB2, and this week is showing you a tooth where I am almost certain this tooth doesn't have an MB2. And I think it's really, really, really important to demonstrate the fact that we can look for an MB2, but if we look too hard, we can cause more damage. But before we get into the case, what I do want to say is that when we look at the metrics of the channel, over 50% of the people who watch these videos are non-subscribers. So if I could ask you to do one thing, it's quick, it's easy, and most importantly, it's free. It's just to hit that subscribe button. If you hit the subscribe button, it pushes me along to do better content, improving the videos over the course of the years I've been doing this. And also, if you want to bring the support even further for the channel, we've got a membership program. The membership program is run by YouTube. Just follow the link in the description. You get early access to content. So these videos are usually done about 3 weeks or 4 weeks ahead. So if you like this video and you want to see the up and coming videos, become a member. We've also got exclusive content. We've got a fantastic endodontic access video, and also we've got a newly qualified dentist video as well. So it kind of gives you some tips on your first couple of weeks as a newly qualified dentist with regard to root canal, of course. So if you look at the case here, this is a upper right 6. This is an internal referral from a colleague of mine in one of the practices that I work at in North Wales. And essentially, this patient had a restoration placed on this tooth, and then subsequently over the next the weeks after, she started to get an aching pain. And then when we take a periapical radiograph, we can see that there's obvious decay underneath this restoration, and also there is, I would argue, some sort of apical radiolucency on the palatal root. So the patient, of course, was consented, they had a consultation, explained everything, and they were happy to go ahead with the root canal treatment. So the first thing we're going to do is we're going to place our rubber dam. And as you know, if you like a lot of my videos, I like to do a little bit of a wiggle. So I place the rubber dam clamp onto the tooth with the rubber dam. I put the rubber dam over, and then I open up or disengage the rubber dam clamp from the tooth. And that makes the rubber dam fit underneath the tooth and get a better seal. And then I'm just going to essentially access the tooth. What I will do is I'm going to have to remove all of the composite filling, but once we remove the composite filling, it's transpires that this tooth has been accessed by the referring dentist, and that for some reason they've used PTFE, which is my preferred dressing type. I feel like if you use cotton wool, it gets sort of stuck in all the temporary dressing. But when I access teeth, especially upper molars, like to do a small kind of access hole first, see where the canals are, and then I just refine the access. And this make sure we do this sort of conservative access. So I'm just using the high energy ultrasonic, a little bit more fast handpiece, and I look at the base of the cavity, and it's super unusual. It is very unusual, and I think straight away I'm thinking to myself, I can see 3 canals. Because it looks so unusual, am I going to be able to find this MB2? I feel like the DB is probably a little bit more palatal than I'd like. but we're having a little fiddle around. I'm also at this point, I know where the DB is now because I've obviously treated the tooth, but I feel like the DB is it supposed to be so distally palatal in this case? So I'm just having a little negotiate round with our size 10D finder, and I just confirm that is genuinely the DB orifice. Sometimes it's really easy for you to sort of get a little bit blinded to everything and go in the wrong direction. So again, I'm breaking one of my rules here. I am doing the shaping in 2 teeth at the same time, and what I'm doing is I'm just opening up the coronal third with my glide path file in the mesiobuccal and distal buccal, and then I'm also going to use an orifice opener here, and this further confirms where the DB canal is. So I don't like to do 2 teeth. I like to do the sequence of files in one canal, sequence of files in another canal. But in this case, I just wanted to make sure that I have the proper orifices, and also we kind of kill 2 birds with one stone. Is essentially we like to irrigate the tooth all the way through the process. And if I open up the MB and the DB, then obviously this gives it time to get inside the canal more than it would as if it was closed up with our irrigants to kill the bacteria. And don't forget, 90% of the bacteria is found in the coronal aspect of the tooth. So you want to make sure you are disinfecting this tooth as early as possible, just to make sure it's soaking in the disinfectant for as long as possible as well. So we've opened up the DB and the MB, and now I'm ready to go down our palatal. But we can see here again that the DB it does sit quite distal and palatal, so it's unusual. So I've just got to keep on my toes in this situation, and I don't muck up, and I don't sort of cause a perforation or go down the wrong sort of tube. So I am now going to use I'm now going to get the working length for our palatal. I'm actually using our longer file in this situation. I'm using a size 31 file because I feel like the palatal is quite large. But actually, when we hook up our file to our apex locator, we're straight to length. This palatal canal is really nice and wide, and it transpires that I didn't really need to use that size 31, because when we take the working length and we measure the 0 reading, it's seen to be 23 millimeters. But sometimes you look at a palatal canal on an X-ray, and it's quite big, and you just want to anticipate using longer files. And the problem with longer files, of course, is that I think anecdotally they're easier to fracture. I wonder if it's because it's so long, it's easier to twist and it's easier to break. So that's kind of like the catch-22 with using the longer files. But the shaping in this tooth is pretty straightforward. Of course, we're just going to use the size 15 and the size 25 to shape everything up, and then obviously we're going to finish up with recapitulation. And what I mean by that is we're just going to get the hand file down to the working length just to remove any debris, and of course give it a little bit of an irrigant out. So we've done the palatal. We're now ready to negotiate down the mesiobuccal canal. But what I noticed with this is I am not dropping to length like I did with the palatal. And the worst thing for us to do here is to push it really hard and force the file. All I'm going to do is I'm just going to get to the point where I feel like there's super resistance and the file isn't negotiating any further. And we check the working length is about 18.5 millimeters. So what I'm going to do is I'm going to get a glide path file, and I'm going to shape this to about 18 millimeters, so about a millimeter away from the furthest point reached. And give it lots of irrigant. I'm not going to push it any further, and then I'm going to use my size 25 at about maybe 17.5, and this is just opening up the canal, making sure that the file isn't getting gripped when I'm trying to get to length. And then we take our size 10D finder again, and now we've opened up the sort of coronal to mid third in this MB canal. This is now dropping really nicely to length, and of course when we hook it up to the apex locator, we're now past 0, and we're just going to push the file out and then back up, and then that's our 0 reading, and then we just move the stopper. All pretty bread and butter stuff, easy stuff. And then when we do our working length, then we've found that we're at the zero reading is at 19 millimeters. So, you know, we get on with this really, really nicely. And I suppose in a way, I'm worried about how difficult it was to get to length. So rather than going straight up with our 25, I'm just going to use a size 20 high flex file at the working length, just so when we use our master apical file, our size 25 high flex, this is not putting too many stresses on this this file, because, you know, if you are if you're going too far up quickly with a high diameter file, you're likely to fracture the tooth, but also you're more likely to ledge. When you ledge, it's a pain in the backside, isn't it? And what I would say is we've cleaned the palatal, we've cleaned the MB canal, and now we're ready to do our DB canal. And this was pretty straightforward. You know, I'm not going to spend too much time on this. The file negotiated quite nicely to length. We did our apex locator reading, and then we shaped it, and it was all tickety-boo. So we're at the point now where we've shaped all of the 3 canals. We have recognized that the base of the cavity floor is slightly unusual. So now we're going to need to look for our MB2. And if you didn't know, what we do is when we're looking for an MB2, we're going to draw a line from the MB1 to the palatal. And then we're going to draw a line perpendicular to this from the DB, and this is kind of the area that we're looking for. But in this case, the DB is quite far backwards, and I suppose in a way, this sort of way of looking where the MB2 is going to make this this sort of way of looking for the MB2 a little bit further palatal than we'd like. And what I'm concerned here is if I use this kind of technique or measurement to find out where the MB2 is, we're going to be perforating the tooth. We're going to be looking for the MB2 orifice, but this is kind of where the apex of the furcation is. So we're always thinking about technique, but always thinking about the clinical situation. We don't want to blindly just follow rules. We want to use our nous. We want to use our head with things. So I'm obviously just going to aspirate the cavity floor, and we can see that possibly, maybe, if we look at this tooth, there is an MB2 which is quite close to the MB1, and maybe if we sort of pause it here and we have a little look, we can see that maybe there's a root fusion line. I'm not sure, you know. So I get my size 10D finder, and I have a little feel around, and maybe I can feel a catch, but it's not negotiating like I would like to. And so what I'm going to do is I'm going to get my low energy ultrasonic diamond tipped ultrasonic tips here, and I'm using a ball ended tip here. And I'm only using a ball ended tip because I fractured my nice torpedo ultrasonic tip, and that's my preferred use. But in this case, you know, things break. So we have another little look, and maybe is there an orifice there? I suppose to the person who wasn't there at the time, you think that is definitely an orifice, Sam. You need to, kind of negotiate this. But again, it's still not really obvious if it isn't or is an orifice. So it's about making sure that you are just being really, really careful and judicious, and also if we kind of just pause it here, we'll notice that I am not looking for the MB2 in the traditional sense where I'd be looking for the MB2. It's a little bit further towards the MB, and we can see here that, you know, it's that kind of an orifice that we thought was an orifice is now completely disappeared, and this is now just the pulp chamber floor. But alas, I want to find the MB2, so I'm going to have another little sort of negotiate round, have another little feel around, a bit more ultrasonic. I get my size 10K file in the area where I thought there might be an orifice, maybe with that root fusion line, but there's absolutely nothing at all. Bit more irrigation, bit more ultrasonic tips, and then I'm going to get my ultrasonic my endodontic activator here. So it is an ultrasonic tip, but it uses the most gentle energy of all my ultrasonic tips, and I'm just having a very, very sort of gentle feel around. And we can see here that this troughing that we've done there's absolutely no hole here at all, and I am convinced that there is no MB2. And I suppose in a way, if you look at this tooth and you've not done the root canal treatment, you might say, well, 90% of teeth have MB2s, but I'm pretty confident in my ability to find MB2s, and I think with high magnification, with a judicious look for this orifice, there is no orifice. So in this case, I'm happy there is no MB2. Of course, you could take a cone beam CC scan, but I think that's probably an excessive use of a special test or radiation. So now we've confirmed there's only 3 canals. We're ready for our cone fit radiograph. And what I don't notice here, and when I look back at these videos, this is why it's great, these videos, because you kind of like, you reflect on things, is that when I place my MB cone to length, shall we say, we notice at the point where I've crimped the MB doesn't actually reach the reproducible point, doesn't actually reach the point, the MB cusp. And in this case, what I don't notice is that this MB cone fit is actually short, and it's pretty obvious here that it doesn't. The point where we've crimped this GP cone doesn't actually reach the point where the MB tip of the MB cusp is. And when we look at the periapical radiograph here, we can see that it is genuinely short. Now this could be to length, with hindsight, I know it's not to length, but what I would say is you might think to yourself, well, that's just the way it is, and we'll just fit it in. And me personally, I am not happy with where this MB GP cone is. So what I'm going to do is I am going to remove all the GP cones. I'm going to place them into my disinfector, and then I'm just going to retake the working length in the MB. So I'm just going to confirm for definite that this is the working length that I got last time. And when we take it out, we can confirm that it is actually 19 millimeters. So we know the working length is correct. So essentially what we've got to do is we've just got to make sure that it's shaped properly, and also the GP cone fits properly, because it might be a bit blocked, it might be not shaped all the way to length, and also we might have just had a GP cone that didn't fit very well. And what we'll notice now is I've got a new GP cone, it's crimped, and now it fits properly to length. And when we take the periapical radiograph, we can see that now it's within the acceptable working length of the MB radiographic apex. And then it's just ready to obturate. It's pretty straightforward. Sodium, we've got to do our final irrigation protocol. Sodium hypochlorite activated, 17% EDTA activated, and then the final rinse of sodium hypochlorite. I'm using 2%, although at the moment I am having serious doubts about my concentrations, and I am thinking about moving up to 5%, but that is a whole different video to talk about. I know a lot of people like to use high strength. And then my X-ray, my first periapical radiograph, it's a little bit of a controversial one, but my DB canal is obscured by the palatal, and you might ask yourself, well, do you just leave it that or what? Or in my opinion, what I want to do is I want to readjust the periapical radiograph so I get a proper assessment of the obturation of all the canals. And it was difficult in this case because this patient had very small mouth, and it was difficult to get the periapical radiograph in, but we've taken a second one, and we can see here the second periapical radiograph, and we can just about see the tip of the DB. So it's not kind of Instagram ready, perfect image, but it gives us the information that we require, and that's it. So I hope I have explained myself a little bit about finding MBs. And I hope when you look at my videos, you're not thinking that I'm not looking for MB2. I am genuinely looking for MB2. What also you've got to realise is that when we edit these videos, these appointments are about an hour and a half to 2 hours long, but the videos themselves are only 20 minutes to half an hour. So don't forget, a lot of things have been cut out. And also, you'll notice here that I haven't really concentrated much on talking about shaping or the obturation, and I've really sort of skipped over that. And today's video is really talking about Find MB2. So a lot of the times, if you watch my videos, you might think, well, he's not looked for the MB2, but I have. I just haven't sort of highlighted the fact, because it's not really the theme of that video at any time. So I hope that clears things up. And I just want to say thanks for watching. Honestly, I appreciate all of your views, all of your comments. I love looking at all your comments. I've learned so much on here. So if you feel like something could have been done differently, or something could have been done, or you've learned something, just pop it in the comment section below. I've learned so much from this, and my practice over the years, from when I started this YouTube channel 2-3 years ago, my practice has completely changed, and that is all down to the viewers. So I'll just want to say thank you, and I will see you in the next video next week. Bye bye.